So we'll now invite our next and final speaker, Dr. Seto, who will be speaking about, do we need contact precautions to prevent hospital spread of ESBL? And between the two of them, we managed to bring it back on track, so we are right on time, and we'll have a couple of minutes for questions. Thank you.
Yes, thank you. And since we are right on time, and the last two speakers were so intense, I've got to show you Hong Kong, all right, just to relax. Okay, and Hong Kong was a British colony, and we returned to China. Just for your information, this is the flag of China, and China allowed us to have our own flag. And really, the next slide, just quickly to describe Hong Kong. This slide speaks so well of Hong Kong. This is our parliament, and before that, we belonged to China, so the Bank of China is right behind, taller than the Parliament building. Then the British came, and see, this is the British Hong Kong Bank. It's much taller than the Bank of China. Then just before we went back to China, they built a new Bank of China. And to make sure that it's taller than the British, they put two long flagpoles, see? So you know who runs Hong Kong? Definitely not the Parliament. Okay. Now, but today, do we need contact precaution? How can I say no, right? You know what I mean? The answer is yes, because, don't ever underestimate the superbugs. They even get the food, So how can I say no? So we can end the talk now and take questions, right? But just to let you know, I was invited, in fact, recently in October 2010 to the IDSA, the last IDSA, and there was a debate. Now, this is not the title. The title was, is isolation needed for ESBL? And I was supposed to be against the motion. I'm dead, see? So I changed the title, and I put there, is separation needed? All right? Now, so today, I did not go to the debate. I was shivering. Then, lo and behold, came the biggest typhoon in history. I'm serious. The biggest typhoon in history swept through Hong Kong, and I couldn't fly. So I didn't go to the debate. And Weinstein stood in for me. You know Weinstein from Cook County, and he lost the debate. Now, since I did not show the slides, so now I'm sure maybe Andreas, you know about this, so now I can use the slides, you see. All right, now, anyway, back to this topic. I will change it a little bit. It's not so much contact precaution. But traditionally, as you know, separation traditionally is part of isolation, right? In fact, if you don't believe me, this is the definition from the APHA, the American Public Health Association, that when I first do infection control, that little book was the Bible. And this is a definition. See, isolation. Now, quarantine, I'm not going to go to it, but this is also the definition. So the classic definition of isolation is you must have separation, right? So today, I want to say, should we do contact precaution? Yes, but do we need contact precaution with separation? Now, that we can discuss, all right? Now, if that is not within what you expect, then let's still wait, because we still have question time. Okay, now, another example is the 1996 CDC guideline. And clearly, the CDC guidelines in 1996 states that you need to put the patient in a private room, right? You see, it means separation. But even then, surprise, surprise, unnoticed, a very small footnote, and we Chinese have small eyes, but we pick it up, see? Right? You see? Don't underestimate our eyes. There's a small footnote which says, when private room is not available, place patient in a room with patient who has active infection with the same organism. All right? So even then, it's sort of allowed. Okay? Now, then the new CDC guidelines. And now, right before our face, it's not even a footnote. It's under the different category now, airborne, contact, droplets, they put there. So let's go to contact precaution. A single patient room is what? Is preferred, see? Now they recognize that single rooms are very expensive. And look, when I was growing up in Hong Kong, there's no such thing as single rooms, except for the very, 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 very rich. Okay? I got to add another very, really. I mean, we don't know what is single room. Look, many of us Chinese don't, we go up sharing rooms with our siblings, right up to the time we get married. I'm serious. And what are you talking about? A single room in hospital, you see? So anyway, here in the CDC guidelines, they say a single room is preferred now. And in fact, it says here very clearly in the 2007 guidelines, when single patient rooms are in short supply, prioritize, right? So is this possible? Is it valid? Okay, now in fact, to again show you the chart, the table in the 2007 CDC guidelines, clearly they say that it depends on local and state and regional, and Hong Kong, of course, is not part of America, so we can make decisions, all right? Now, it is thus accepted that there are situations in which separation may not be absolutely necessary, all right? So, there you are again. Actually, this is the 2006, but 2007 is just an update. It was a draft, so no single approach. Okay, now, let me tell you then the story from here, how this all came to me. SARS, again, all right? So SARS in Hong Kong, for the first time in my life, now I've done infection control for many, many years. I won't tell you how long, you know. In fact, let me say, probably before DigiPrete started, SARS came to Hong Kong, and I've tried before that years and years to introduce hand washing, we call it in those days, all right? Then suddenly, it reached 90%. I couldn't believe it. Now, this is SARS, and this is all the healthcare workers infected. I won't go into it, no time. But for the first time, there's one more slide, that's right. Now, for the first time, this is our survey we done. Hand washing went up to over 90%. Now, it's not a surprise because, you know, in the old days, if a doctor don't wash his hands, who get infected? The patient, right? You don't wash your hands, the patient get a urinary tract. Now, I don't know of any doctors who don't wash their hands, and he goes home with a urinary tract. Does it happen? No, it doesn't happen. SARS is different, right? SARS, you don't wash your hands, you go back with SARS. So I said, wow, for the first time in my life, this is it. You know? So we were so busy doing SARS, so when SARS ended, I said, let me look at the MDROs. Maybe it's gone. You see, I don't care about the chickens and the pigs, you see? You know, here we reach 100%. So I took out the MRSA. I'm serious. When I first took out this data, it really broke my heart. I mean, I spent my life preaching, teaching, and then now I got it. You know, and then look, the P is 0.89. I say, hey, hold on a minute. Maybe this is not hospital-acquired MRSA, right? You need the 48 hours. So I was hoping, and as I punch it out, and the 48 hours, the P is still 0.8. You know, and it broke my heart. Seriously, I really asked myself, did I did the right thing? I mean, come on, this is it. And we're still not getting it. Then, fortunately, as I was just about to commit suicide, like Qi Yuan, remember? To jump the river, you know, I came across Lehman's study. You know, and Lehman is a German. Now, to show to you that conferences like this are very good, I've quoted his study for some time, and I met him here. Now, I know he exists, but there you are, see? This is, by the way, this is not Lehman, huh? You know. And this is Lehman and Seto, we met. See, you see to prove to you, this is the name tag, you see? You know? Now, by the way, Lehman and Seto is not a publication, so don't look it up. We're just together, all right? We took a picture. But anyway, I came across Lehman's study, and it's a fantastic study. Now, this is very simple. It's 1,500 beds, and in fact, I talked to him. He assured me that I quoted him absolutely correctly. You know, I seldom do that, but this is one time I can assure you. The author assured. He says, you're totally right, all right? So listen to this. 1,500 beds, and what he did was, from patients with MRSA, gram-positive, VRE, gram-positive, and a bunch of gram-negative, he took 3 of the following, gram-negative that is resistant, not all gram-negative. Gram-negative resistant to the following class, third generation, blah, 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 blah. You know what I mean? He then took, from these patients, he took 20 environmental samples. You know what I mean? That means for every patient with this bug, he took 20 environmental samples, including hands. Now, he also do pulse field to make sure they're the same. And he says that during the time when he did his study, patients may have shared room in a double room, but the partners in the double room was never affected. So the samples he collected was definitely from the index case, right? You know what I mean? So that's very interesting. And then this is what he found. For the gram-positive, the 20 environmental and hand cultures were 25%, while from the environment, it's only 5%. Now, in other words, Probably, we do not know why, but probably because we all know that the gram-positive survive much better, right? You know what I mean? Now, of course, these patients are not those with diarrhea, they're passing out millions. But even those, you know what I mean? When you do diarrhea, you go to the toilet, right? You know, yeah, sometimes you can't control yourself, but most of this, you know. So, whatever it is, when the gram-negative reach the environment, if you cough it out, and so on, or in a wound, it dies quickly. That's our experience too. The moment it's dry, in fact, I've done a lot of environmental cultures, when it's clean and dry, we don't find gram-negative. You know, it's gone. So, what Lehman did was, he also then, these are the environmental cultures. This is the gram-positive, this is the gram-negative. You see, the gram-positive remain consistently high, and the gram-negative remain consistently low. All right? Now, then also, he says in his study, in his paper, that the intensive care units do cleaning 2 times daily, while the general wards do cleaning 1 time daily. So there's the difference. Of course, it's only comparing 2 times daily and 1 time daily, all right? We do not know if you do it every hour. It's impossible to do it every hour. But anyway, 2 times daily against 1 time daily. And he found that for gram-positive, it doesn't make a difference. See? It's 26%, 23%. So 2 times daily is 26%. 1 time daily is 23%, all right? 2 times daily for the ICU, gram-negative, is 8%. And in general wards, you know, 1 times daily is still 2.6%. So cleaning doesn't make a difference, all right? Now, by the way, I can tell you now that Lehman says he still believes this, and his hospital practices it even now, all right? Okay, now, so in his conclusions, this is what he says. Environmental and hence contaminated by gram-positive is more frequent than gram-negative, all right? Number 2, this most likely is due to gram-positive survives better in the environment, all right? That's the reason. Number 3, and this is not in the results from his study, but just from literature review, cross-contamination of gram-negative is like 5 to 23%, while gram-positive can be very high, okay? Now, the 4th bullet point, different environmental disinfection in his study shows no impact. 5th bullet point, therefore, isolation in a single room with contact precaution is highly recommended. In fact, I don't think you can get away with it if you don't isolate MRSA. You somehow spread. But single room isolation for gram-negative, especially if you practice contact precaution and do hand hygiene and so on, may not be necessary if you need to prioritize, all right? Now, in fact, if you look at the 2003 Shea guidelines for MRSA, it already hinted on this. This is the Shea guideline. And it says that, according to mathematical models, the high rate of transmission of MRSA suggests that, in green, that reliance on hand hygiene alone, you may not control it. You need contact precautions, all right? Now, so, hey, there you are. Yeah, my MRSA is high, remember? Let's go back to the SARS story. Remember I showed you the MRSA didn't drop. And the man came and says, it didn't drop because hand hygiene alone, even 97% during my SARS, is not going to work alone, see? Then what about my gram-negative? See? So I quickly go back to my, get all my stuff, gather the gram-negative, and the Pseudomonas, the P was 0.0028, all right, it drops, wow. And then, in fact, the gentamicin Pseudomonas even dropped more, okay? And then, of course, ESBL, see? It was 0.04, not as impressive, but it's still significant. I think it's because the Chinese eat chickens, you know? Lots of them. Okay, but still it's significant, see? Hand hygiene can make a difference, all right? And in fact, to make sure that you don't criticize me, we did segmental regression, all right? This is just to show you that with segmental regression is not so much because the time frame is not enough, all right? We did it, okay? Now, then we came to Cyanobacter. Oh, what happened? Just not significant. So I was wondering, what's going on? And then I read my textbook of Mendel. You know, do you still read Mendel? I hope so. You know, now it's so easy to get papers. Now you just read people like Peterson, you know, who reads Mendel. But anyway, this is what Mendel says. Page 263. A cyanobacter may survive on dry, inanimate objects for days, comparable to Staph aureus. A cyanobacter can be found on both animate and inanimate objects. Up to 25% of healthy ambulatory adults exhibit continuous colonization. It is the most common gram-negative organism persistently carried on the skin of hospital personnel. In fact, let me tell you that a cyanobacter can, in some way, behave like a gram-positive. Okay? Now, to support this, there was a study that just came out around that time. In fact, this is a very simple study. What he did was his ICU converted to isolation rooms. You know, that's a good idea, you know. If not all isolation rooms, in fact, I don't have the time to show you one of our studies. Our ICU built 10 isolation rooms after SARS. You know, we have lots of money after SARS. You want any isolation room, zoom, the government comes up with the money, all right? But this one, they converted their ICU from cubicles to isolation room, and he tracks it. And very quickly, because of time, just to show you, the colonization for Acinetobacter fell. And before, pulmonary colonization was much, much higher than after they put them into this isolation room in the ICU. And his pulse field and all the statistics are done. All right? Now, so for Acinetobacter is an exception. Then, so this is his conclusion. But why is it not noted in Lemon's study? You know, he didn't mention Acinetobacter. What happened? Could it be that in Germany there is no Acinetobacter? Lucky Germans. No. Now, take a look, because his numbers were too small. Okay? Now, so I will submit to you that, you know that for CDC guidelines, and in fact, this is a principle, they say that for MDRO, you should have a two-tier system, right? Two-tier system. And this is the first tier. Now, it's not word for word. I adjusted a little bit, but like for instance, now the first tier is mandatory. You should consider it that way. No debate. If you want to control MDRO and do not do lab testing for sensitivity, forget it. You know what I mean? No, it's non-negotiable. Go to your hospital administrator and says, no testing, no go, right? You know? So, and also, by the way, if you are testing it, make sure you notify the infection control people. You know, why not? You're already doing it, see? Now, so this is not negotiable. But you come to tier 2, in the CDC guidelines, they say you pick and choose depending on your own situation. All right? And in fact, you all should do that in your own country, or if not in your own hospital. We did that in Hong Kong. And at the moment, this is we did it for all the MDRO. So this is what we do for tier 2. But at the moment, we don't say that you need to isolate ESBL. Now, why? Because we have tracked the trend and it remains stable. So these are 208, 209, 2010 data. Now, when we say don't isolate, we just simply mean we don't put them in single rooms. You know what I mean? We still insist on contact precaution, which we know the staff is not going to do it perfectly, especially when they're busy. But I think the gram-negative, as shown by Lemon's study and other data, that for gram-negative, because their contamination may not be that high, so there is more room for labs as compared to the MRI state, all right? So if you have to choose, that's what we do. And if you can track, and really for 208 to 210, we do find that our ESBL remains stable. So the present policy is, if you get an ESBL in Hong Kong, and unless there are rooms, you won't be isolated. You will be put in a cubicle with the rest, and we implement contact precautions, all right? Now, by the way, there are also reports that ESBL can work by standard precaution. This is the data. And there's also another paper, which I also give the reference, that contact precaution fails. And then it's reinforced. You know, they teach, they educate. Now, they did not clearly say whether there are single rooms, but they reinforce. And then it works. See? Now, can I submit to you that maybe even without a single room, if you reinforce, it may also work. All right? Now, so, in fact, I got download from one Canadian hospital. I won't say which it is. I can't remember which it is. But this is the recommendation in one Canadian policy, that if it's ESBL, you may decide isolation may not be needed. All right? So can I submit to you that, you know, for ESBL, if you need to prioritize, the gram-negative and ESBL really belongs smackly to it, is one thing that you can not put on the top. But please, it does not mean you don't practice contact precaution, all right? Now, did I win the debate? I didn't show up, see? I don't know, I hope I can win if I presented this. But if not, come to Hong Kong, you know. You have seen the morning view. The evening view is even prettier. This is it, man. Thank you very much.
Thank you very much. Because the dancers already left, I will ask the previous speakers, all of them, to dance before of us because. No, but we have some time for questions. So please, would you come here and answer questions and.
I guess the question is again, first of all, wonderful talks, all three of them. But David said that we have a lot of ESBLs in the community. And Seto is saying, you know, we can not put them in single rooms, but we have to practice contact isolation. But I think when you're trying to convince your administrators about this, because contact isolation is also going to generate a lot of, you know, more cost, the price of the gowns, etc., all that. I think there is some contradiction here. If we're saying it's all over in the community, but when they come to the hospital, especially when they're not in critical care areas on the open units, if we're not dealing with open wounds, if it's a urinary tract infection or, you know, something without draining wounds, why do we really need to isolate since it's all over the community? I mean, to put contact isolation.
I'm going to just give my opinion, then we can maybe all should give an opinion as well. I think the organism is what matters in terms of the infection control. I don't really care what type of ESBL it is, but I think Klebsiella historically has been more of a hospital problem. You know, looking way back at, you know, gentamicin-resistant Klebsiella and then you know, onto ESBLs and now with carbapenem-resistant Klebsiella, that it's more of a hospital problem. And my personal viewpoint is I still think ESBL-producing Klebsiella I would lock up in a single room and I'd be very strict on contact precaution. ESBL-producing E. coli, I'm not as sure, and particularly if, you know, 4% of people in Holland and maybe it's 40% of people in other countries are coming in, walking in with ESBL-producing E. coli, and sure, there are a couple of reports of hospital outbreaks of ESBL-producing E. coli, but I'm less convinced of the need to isolate ESBL-producing E. coli compared to Klebsiella. But this is just my opinion. It's not based on data, and I'd love to hear other opinions too.
I guess that's the point, because in my hospital in Lebanon, for example, close to 35 to 40% of our E. coli are ESBL producers. And I do fully agree with the Klebsiella, which is more a hospital organism, but the E. coli is more the concern here.
No, I think you should appreciate that if you were to look up most guidelines, no one still dare to say no contact precautions, you see? But really, to be very honest, I'm sure it's true in Lebanon too. The most expensive are the single rooms. You know what I mean? I mean, the alcohol hand rub, if you need to be save cost, the WHO form, you know, the alcohol hand rub in Hong Kong costs 40 cents US per 100 ml. You know that our newspapers cost 60 cents US? So it's cheaper than a newspaper. In fact, sometimes I say, you know what can you buy for 40 cents US in Hong Kong? What can you buy? You can buy the WHO alcohol hand rub. You know, so the masks and so on are now very cost effective. You know, the mask in Hong Kong, the surgical mask is only 14 cents. So no big deal, you use more, but then the room that is the problem. And it's the room that we need to prioritize. So as I contend that, you know, we still wouldn't dare to say that you don't need contact precautions. It's just that we need to prioritize rooms as recommended in all international guidelines. So that's where, I don't know, what do you think?
Well, we have just started a trial to see if single rooms make a difference. I think that's what we need, because if it makes a difference, we know not much about epidemiology of gram-negatives. Gram-positives are much better known, I think. And especially with the carbapenemase coming, I think we really need to know what is the added value of a single room. So hope we can answer it in 1 year.
Could you comment about possible interventions in the community, either directed to human behavior or directed to human behavior with animals?
I mean, I don't think we know, well, I don't know enough about E. coli transmission in the community. Obviously it occurs, So I guess one thing is getting the food, but then clearly there are examples of family outbreaks of E. coli infections with common clones.
So moving to single rooms.
In China, they share rooms, I heard. So
I think in India we have much the same situation as yourself. So there's a very high percentage of ESBL, E. coli, and Klebsiellas. So we at present are not isolating in single room. We are using contact precautions, but at the same time we are also very critically looking at them in terms of gown usage especially. So without really becoming slaves of the guidelines, we look at it from a case-to-case basis, but definitely hand hygiene and the the other standard precautions which are there, but maybe not so much of gowning and masking, maybe only in particular situations where needed, because it doesn't make sense when the prevalence rate is so high. It's not cost-effective.
I think for the community, basic hygiene, what we all know, but well, all these observations in toilets show that a lot of people don't adhere, but I think that is what we need to do, to stress that basic hygiene still is important.
But I don't know if you have any expertise in that, but do you know if there is any way to really create smaller groups of animals within farms, so there will be no spread within huge amount of animals?
They're setting up different models in farms, and what they've done up to now is increasing the volumes and not implying good hygiene. And antibiotics were really used as a kind of an aid to mask all the bad practices. And what they try to do now is segregate the groups a little bit more and have improved hygiene. And apparently in Denmark they have good examples that you can work with hardly any antibiotics and the same production levels.
Thank you.
My name is Günter Kamp from Hamburg in Germany. I have a question to you. When you talked about the increase of resistance in E. coli in poultry and humans in the same year, now I guess chicken is usually cooked or fried, so it's very unlikely that living cells were still on the meat. Do you see the transfer by manually handling the chicken for food preparation, or was it maybe uptake of resistance genes in the human gut? What is your hypothesis?
Well, we all know that if you are very cautious in the kitchen, that there is a very limited risk of transmission. However, most people do not adhere to the rules again. We know Salmonella, Campylobacter comes from chicken and goes to humans. And I think that the breaks in hygiene, if you eat well-prepared chicken, there's no risk, in my personal opinion. I don't know if the plasmids survive or in any viable form. I'm not sure about that. I think it's mainly the handling in the kitchen, after cooking, putting it back on this, where the raw meat has been. These kind of things, in my opinion, are most important.
Okay, thank you.
So Kentucky Fried Chicken is good for you, is that what you're saying?
I'm not sure if it's good for you.
Hello, Marjolein Kluitmans from the Netherlands. I have a question for Professor Seto.
Oh, yes.
How do you deal with sharing toilets and bathrooms when you're putting ESBL positive patients in multi-occupancy rooms, so with other patients? Are they then sharing the toilets as well, or do you have just dedicated toilets?
No, this is the problem. When you put contact precautions, this is one reason why, if you want to be serious in isolation, you need a single room, all right? So when you put them not in a cubicle, then you allow labs, all right? And our contention was that from the Lemon study, that because gram-negative is so much less in the environment compared to gram-positive, that even with the labs, you may have a better chance of getting away with it. Now, but back to your toilet questions, some of the things we did was, and it's not foolproof, but one of the things we did was, especially when the patient is sick, we do have a minor staff walking through the ward every hour and announcing that you need to go to the toilet, and then they bring the patient to the toilet, okay? So that to ensure that before and after they would do all the necessary hand hygiene and so on. You know,
Thank you.
that's what we do. They have a little vest, you know, I wish I brought the slide. They have a little vest that says in nice Chinese that is to help you in the toilet, you see. You know,
Okay.
or, yeah.
I want to make one comment. Not all gram-negative were created equal, so I think we should be careful with the statement.
No, sure, Cyanobacter, remember?
And others.
Yeah. I think, yeah. Yeah, like ESBL, Klebsiella, and E. coli, right? See?
But would you put a key PC producer on a ward? Klebsiella with carbapenemase?
Now, to be very honest, sometimes we isolate cases also for political reasons. Now, if you remember my chart, the carbapenicillinase are isolated. If there's an NDM1, all right, he gets isolated. Last year in Hong Kong, we only have 2 NDM1s, all right, and both got isolated. Now, I have no evidence to show that they spread better than the ESBL, you know what I mean? So, but they get isolated.
We are going to present in the future ECAC a work on environmental contamination and survival of KPC producing Klebsiella, which is very high, with numbers close to MRSA, I would say.
Okay.
Yeah, I'll be in the session, right?
Yeah, go ahead. Thanks all for the great presentations. I have my name is Maha, assistant professor from Jeddah University, Malik Abdulaziz. The real question, I think, when do you take them out? Do you rely on the 3 weeks negative culture every week of antibiotics? Is this really effective, or are they going to colonize again? Because we keep having this problem. Are we going to isolate them or put them in contact isolation indefinitely, or do you have a better approach? I think this is my real dilemma. Thank you very much.
Yeah, well, you know, the CDC, if you look at the MRSA guideline, there always is 3 negative cultures, but they will tell you, including Jarvis, that it was just arbitrary. It's not that there's a study, all right? For us, it's 1 culture. If it's turned negative, you know what I mean? Now, but having said that, let me say this. It's 1 culture, but has some common sense. If it is still a discharging wound and you can't cover it, you know, you've got to test it again. Now, another thing is this. Generally, we let the patient go home because I am not convinced that there are anything we can do to prevent community spread. So like flu, you know, in the hospital, if there's a flu case, we try our best to do dropless precaution. But if it's good enough to go home, they go home. You see? And of course, in Hong Kong, we do have a study, our group, showing that hand hygiene at home do reduce the infection rate. You know, the control is 10%, hand hygiene is 5%. It's the first study showing this. So to answer your question, we let them go home. Because once they go home, it's not our problem.
What if they chronic? What if those
they can't, then we have 1 negative culture. Okay?
I am going to differ my opinion. For ESBL producing Klebsiella, I have them locked up forever, and in future admissions as well.
And we do too, so you can do anything you want.
Yeah, we also let them go home, but with a lot of education on and stress on hand hygiene, because as you know, in the community. So, you know, we are aware of that, and we give a lot of education to the patients regarding the hand hygiene at home and preventive spread between the members and elsewhere.
Thank you for 3 provocative and entertaining talks. On the subject of prioritization and maybe how to think about prioritizing patients, there seems to be a grudging, maybe, consensus that not all bacterial species are created equal. Is there any basis for us thinking that there may be a way to consider that not all hosts are created equal from the standpoint of carriage, that there may be some patients that are super shedders or prolonged shedders because perhaps they've had greater antibiotic exposure, and the diversity of the remaining flora that in which the problematic resistant gram-negative exists, the diversity is low, so the shedding pathogen, the resistant pathogen, is higher or more problematic.
So I always sort of take the analogy of the Curtis Stonsky paper on VRE, where he collected stool samples of patients with VRE and quantified the amount of VRE. And the amount that you've got in your stool correlates with the amount that is in the environment. And people who have it more in the stool were people who got certain antibiotic classes. Now, whether the receipt of drugs with anti-anaerobic activity increases your quantification of ESBL producers or carbapenem-resistant Klebsiella, I'm not aware of any data.
We are doing such a study right now, and we already documented direct correlation between stool concentration and environmental concentration of the organisms. We have not analyzed yet antibiotic use.
Yeah. The other thing, of course, is patients with patients who are incontinent or who have diarrhea, I think, are going to be better shedders than continent patients.
I have two questions. First of all, Tom Gottlieb, Sydney, Australia. Are we sure that gram-negative colonisation in the environment is lesser than gram-positive? We have one experience where we did swab testing and then we used gauze swabs which we put in broth looking for Acinetobacter and other gram-negatives, and the difference was just astounding. So it might be just a sampling that we use that makes the difference, and maybe there is significant gram-negative colonisation. That's the first question. The second one is, I assumed always that if you're going to isolate, it might also not only be about transmission of the organism, but risks to the patient for subsequent outcomes. We've always documented poor outcomes with MRSA acquisition. We didn't know about gram-negatives, but there is a recent study this year from Hajo Grundmann's group which showed that in a case-control study, E. coli ESBL bacteremia had a significant mortality outcome. And maybe in that case, it is an issue, especially in low prevalence settings where you can still contain things. Both those questions, if I can.
We will be presenting tomorrow some results from a MOSAR study, and we have looked at environmental contamination with MRSA and with ESBL and compared them. And there is dramatic difference. You can find a lot of MRSA in the environment. You can find very little ESBL. And if you do also, if you look at the time of survival, you inoculate dry surfaces, you can find MRSA at still significant concentration after a relatively long time, but after a quarter of an hour, you don't find the ESBL containing E. coli and Klebsiella in the environment. Saying that, our results show that the risk of transmission per colonized patient is very similar for MRSA and for ESBLs in rehabilitation center setting.
But I think for Acinetobacter, as you were very rightly saying, that could be different. So Acinetobacter would be having a more rate. So.
Yeah.
No, there's always room for a more thorough study. But then I want to say that even your method of cleaning, because we have just finished a systematic review for disinfection, and there are two clear studies showing that when you use wipes, you then carry organisms, even though with disinfectant wipes, you carry organisms and in fact keep them alive because you recur using the wipes. You see. There are papers showing that.
We have data from an observational study in several Dutch hospitals, and about half of them use a single room for ESBL, the others do not because they don't have them. And we didn't see any difference in transmission rates. It was not standard culture procedures, but that was the basis to do a better organized study, because I think it's an important question, and I think the answer is not clear at the moment if we can rely on standard precautions or contact precautions.
Zaina Kanafani from Lebanon. We just started a study at the American University Hospital looking at colonization in patients who have ESBL, infections of the ESBL producing organisms. And we're looking to culture the skin, the oropharynx, urine, wounds, if any, and to continue to culture these patients for 6 months, 1 month apart until 6 months after discharge, to see if they remain colonized. And we're doing molecular analysis to see if they are the same clones. We've just started the study and we've enrolled only 4 patients so far, but we've only had 1 positive skin from 4 patients. Even the rectal cultures were negative. Mind you, these patients are, most of them have just started antibiotics for their infection. So so the hypothesis may be that when they are on antibiotics to treat their infection, then the colonization pressure in other sites might be low. And if this continues to be the trend in the study, then if they're not colonized anywhere, then why do we have to perform contact isolation?
I think there's
definitely we will do. I hope we will have enough power to do separate analysis for E. coli and for Klebsiella, but this is just what we've had so far.
So I think we're all going to look forward to next year's ICPIC meeting to see the results.
Thank you very much for all the speakers, wonderful talks, and thank you for the audience who participated.